Great. So, good evening and namaskar, and welcome to each and every one of you to yet another session of SAFE hosted by ANEI Patient Safety Fellows. A very, very warm welcome to all of you. Before I invite today's presentation by Dr. Geeta Parwanda, just give me a second. And I usually share few information about what we are going to do and what we have got in place for all of you. So the SAFE full form is Safety Awareness for Excellence. And that's where we start. And this is April, and we have every month we have different sessions. And as I already mentioned, this is brought to you by Patient Safety Fellows, Patient Safety Movement Foundation. The fellowship is being done in collaboration with Patient Safety Movement Foundation. And the only objective here is to create a culture of safety among us, among our nurses, our students, and the message of each one's responsibility to do sleep care and do no harm, zero by 2030 by patient safety movement means that we are aiming to prevent all preventable harm by 2030, and there are lakhs and lakhs of preventable harm in healthcare. So that's the calendar for 2025, and we are here in April. And in May, we will have Enhancing Patient Safety, Reducing Hospital Cardiac Arrest Quality program. So that is Dr. Geeta Parwanda who is going to talk to you today about appropriate use of restraint. And next month, we have Ms. Jyoti Kacherla who will talk about reducing in-hospital cardiac arrest. It's a quality improvement project that has been presented last year in 7 minutes. So Jyoti will be sharing the entire project like we have done earlier. Couple of other projects we have already presented. So that will be done in and hopefully we should be completing that before the Anicon. The Anicon is expected to happen on 31st of May at Grand Hyatt Kochi. And we are inviting each and every one of you to be with us. So great. And we have the early bird offer going on, which will be available till 30th of April. 3,000 rupees for any members and 3,500 for non-any members. After 30th, it 3,500 for any members and 4,000 for non-any members, and on-spot registration will be 5,000. Now we have already received the submissions for the three competitions. It's all closed. And right now, the interim assessment with the interim jury is going on. And there is one last competition that is there announced for leadership challenge. So we are inviting a group of 3 to 4 people maximum, include headed by a senior nurse leader, either CNO, deputy assistant nursing head. They have to come as a team, and then they will be coming on 1st of May for virtual round. You will get the problem to which you have to brainstorm and present the solution same day. You won't get it earlier. So that's why it is called a challenge. And then 2 hours to deliberate, strategize, and build the solution. After that, you will present it to the jury panel. And out of all the groups that come, the top three teams will be again invited, and you can join in Anicon, where you will get another challenge which you have to present in front of the jury there during grand finale. And you will be competing live on the stage. And then From there, obviously, there'll be a winner and first and second runner. So, Annie being a group of nurse leaders, it is important that we challenge ourselves also. So we are inviting the senior teams to register and be there for this very exciting challenge that we are initiating for the first time in Anicon. And it takes courage and what you call it, courage and motivation to come to a place like this. If you are afraid whether I can do it or not, we will never learn. So come, experience, join, and participate. And next year is going to be even more exciting because there is whole lot of talent out there. I'm sure that our leaders can definitely rise up to the occasion. So a very, very warm welcome to this leadership challenge. With that, thank you very much. And it gives me immense pleasure to invite Dr. Geeta Parwanda, a classical example of a very senior, educationist in the country, joining our fellowship program, which shows that learning never ends and anybody can learn anytime. And when we look at Dr. Geeta Parwanda, that is what I think. And I'm very happy that, our fellowship program is attracting senior people because they are invested in patient safety. And all the topics the fellows talk about is patient safety around the clock. And I'm sure many of you joining month after month to, come here and learn and share. So today also it will be the same. So I will have to share the presentation for Dr. Geeta. I would request if Abu, if you are there, I will make you the co-host. Can you manage admitting people? Abu, are you there? Abu, or anybody else who can volunteer to be my co-host just to manage admitting because I'm sharing the slides so I cannot go in and out of that view. Anyone here?
I'll do that, Tankam. I'll do it.
Okay. Thanks, Kaval. So I'm going to make you the co-host so you can keep admitting and mute people as required. Yeah. Thank you. Thank you so much. And Geeta, over to you.
Sure, ma'am. Jai Hind, greetings to all esteemed officials of Association of Nurse Executive, and I'm highly humbled and thankful for providing me a platform, being a ANEI Patient Fellow member 24 batch. And I'm so thankful again to our founder, president of ANEI, Madam Thankam Gomez, who is always a mentor for us to give a path for us for his any learning journey related to not only clinical practice but also for the leadership. So the topic of my presentation today is given use of restraint, which is very meaningful. And when we add that appropriate use of restraints, as we know that it is an important component of patient care. When we know the patient has come in the critical stage, patient is a old or a pediatric patient who needs care, and restraint is a part of the treatment. Coming to the learning objective, I hope at the end of this session the participant will able to understand the concept of restraint in hospital use. They can have gain update in restraint application approaches as per WHO guidelines. The adverse effect of restraint with the review will be discussed, and the desirable and safe use of restraint with evidence-based practice is also a learning objective of this session. Let me come up to the background. I'll be discussing about the WHO quality right, which is very important to mention in this topic, as it is an initiative which aim to improve the quality of care and support in mental health and social service, and to promote the right of people with psychosocial, intellectual, and cognitive disability throughout the world. There was an article by James Luca in All Society of Journal Internal Medicine Journal, that is with update in 2024. The use of restraint in hospitalized patient is associated with physical and psychological adversity of the patient. And one more article, a qualitative study by Sandra 2022, which I'll be discussing in my last slide also, that how restraining patient in acute care hospital made a qualitative theme which was came out of the relatives and the patient care thing, and the main theme was based on scientific, legal, and ethical knowledge of restraint was required. So it is important for us to know the principles of human right and what are the right principles of appropriate use of restraint related to not only scientific evidence proved, but what are the legal and the ethical issues are involved. So the mentioning about the human rights, the points, diversity, human rights, and equality is important as per the WHO guidelines. The key points of WHO guidelines, why we need to mention in this session, because that we need to build capacity to combat stigma and discrimination and to promote human rights and recovery. Second one, to improve the quality of care and human rights condition related to mental health and social service, and able to create community-based and recovery-oriented service which is related to respect and again promote human rights, and also to support the development of civil society movement to conduct advocacy and influence policy making, being nursing professional. Now, let us quickly review the definition of restraint. As per the Council Care UK 2002, restraint is defined as intentional restriction of person voluntary movement or behavior. And restraint are the physical, chemical, or environmental measure which used to control the physical or behavior activity of person or a portion of his or her body. There is a term again, a manual restraint as per NICE guidelines. It states that a skilled hands-on method of physical restraint used by trained healthcare professional to prevent service user from harming themselves, endangering others, or compromising the therapeutic environment. It's also purpose that we safely immobilize the service user. My next slides will be just highlighting the picture of that how the manual restraints are useful not only to save the service provider and also to immobilize the patient. Now, let us quickly review what are restraints. So, restraint, uh, I request the participant, if they want, they can just mention in the chat box also that a restraint, is it a device, is it is a tool, or it is a therapy? Okay. Now, let us come to the purpose of uh, restraints. The main purposes are to carry out the physical examination, to provide the safety to child, to protect the child from injury, and to complete the diagnostic and therapeutic procedure. In many of the nursing procedure, to maintain the child in prescribed position, we use restraints. So I had asked uh, about that what is a restraint, whether it is a device. Yes, it is a device that limit movement to extent necessary for treatment and for the protection of the patient. And this is a device which is used for 48 hours to keep the patient in bed. Let us
I request everyone to stay muted, please.
let us come to the what are the indication for restraints.
Swarnlata, please mute yourself.
Yes, the indication for restraints are when the patient is displaying behavior that is putting themselves at the risk of harm. When the patient is displaying behavior that is putting others at the risk of harm. When we require treatment by the legal order, for example, under the Mental Health Act 2007, when we required urgent life-saving treatment and it is needed to be maintained in a secure setting is another indication of restraint. I'll be using one word is seclusion. Can I ask that in any of the hospital, seclusion word is used by the healthcare team? Anywhere, especially in the mental health setting?
Has anyone heard of the word seclusion? If you have, or you have written it down in your policy, it'll be nice to hear because at least I was hearing it for the first time. So we are getting answer no from Dr. Jyoti. So
Okay.
probably this is something new that you are going to learn. I think it's not very complicated to understand because the word seclusion. So keep paying attention to Dr. Geeta's discussion. So let's continue, Dr. Geeta.
Yes. So the seclusion is also a term, scientific term, and it is used in especially the mental health setting in the asylum, and which defined as the supervised confinement of a patient in a room which may be locked, and the sole aim is to contain severely disturbed behavior that is likely to cause harm to others. So this term is as per the physician order is given in the medical and the health note sheet. So I just wanted, and even I have got the reference from the Department of Health 2015, where it is written in the Mental Health Code 1983 Code of Practice, where this term is being used, and that's why I have mentioned in my presentation. There are certain policy statement which was given by the WHO that restraint shall be used only for incompetent patient in order to maintain physical safety and to prevent injury of harming oneself, staff or others, or interference with medical and surgical treatment. Restraint shall be used only upon written order of physician except in emergency situation. Third point, patient dignity should be maintained during restraint and it should not be used as the means of force, discipline or convenience by the staff or by means to control behavior without any clinical justification. Physical restraint should be terminated immediately when the patient is no longer poses a serious risk of harming themselves or others. These all policy statements are as per the WHO guidelines. Now, coming to the types of restraint, some of the images have already been put. The number one, we come to the physical restraint. Physical restraint is anything near to the body which limits a client movement, and this may be attached to person body or to create a physical barrier. For example, a table fixed to a chair or bed rail that cannot be opened by the client. Now, some of the physical restraint types I'll be just showing you through the pictures also. Mummy restraint, elbow and knee restraint, extremity restraint, abdominal restraint, jacket restraint, mitten or finger restraint, crib net restraint, safety belt, and slide rail and splint. My next some of these slides are showing the pictures of this type of the restraint. The number one is the mummy restraint. The second one, the elbow and the knee restraint. You can see which these are the common restraints which are available in the hospital. The third one, extremity restraint, abdominal restraint, jacket restraint. Then there is a mitten when the wrist is cuffed, so it is finger restraint. Then there is crib net restraint for the babies, then safety belt, and the slide rail and the splints. Now, the second types of restraint is environmental restraint, where we change or modify the person's surrounding to restrict or to control the client mobility. And here you may be seeing in the example, I have used the word seclusion. So, seclusion is the another name when we give a environmental barrier for a sickly critical patient which required restraint. The third one is chemical restraint. Chemical restraint is a form of any psychoactive medication which used not to treat illness but to intentionally inhibit the particular harmful behavior or a movement of a client or a patient. So quickly we review the forms of seclusion and the restraints, which include manual or physical restraint, chemical restraint, and the seclusion that is called environmental restraint. Now, when and why are seclusion and restraints are used? As per the WHO, for example, national law or policy may allow the use of seclusion and restraint to protect people from perceived harm or danger and unhealthy service culture. More information of service
Service
culture
sector
is found
is
in
found in
guidance
guidance
or a
or
lack
a
of
lack of
knowledge,
knowledge,
training, and
training.
resources which may be contribute their uses. So these are again I am repeating my this thing that legal points are very much important for nursing professional to have a knowledge whenever they are applying the nursing procedure of restraint. Now coming to the challenges and what are the assumption. Before that, I have a 3 minutes video which will give the nursing procedure application of restraint, and I request my Madam Tankam to
Restraints are
kindly
used
put
in
it
the
on.
ED to ensure patient and/or staff safety. When it comes to restraints, it doesn't matter which type you use, it matters why you are using it. Based on why you're using restraints, there are two types: violent behavioral restraints and non-violent medical restraints. Staff may need to protect themselves by restraining a patient that is behaving violently. If used for a violent patient, they are called behavioral restraints. Behavioral restraints require provider evaluation and documentation within 1 hour of initiation. Orders cannot exceed 4 hours. And the patient must have a sitter with continuous observation completing Q 15-minute documentation. Violent restraints may only be used for patients over 18 years of age. Other times, an altered, sedated patient may need restraints to stop them from unconsciously pulling at critical lines, drains, and airways. If used for this reason, you are using medical restraints. Medical or non-violent restraints require the provider to sign the order within 12 hours, and this order can be renewed each calendar day, and they require assessment and documentation be done Q2 hours or more often if necessary. A tied restraint must do two things. It has to be secure, otherwise it's not really restraining anybody. And it has to be quick release, in case there's a fire or something and you quickly need to get the patient out of bed. To meet these twin objectives, we use a quick tie knot. In just a second, everyone will get an opportunity to show off their junior woodchuck skills and tie a quick release. Here's how you do it. Wrap the cuff around a wrist or ankle. Make sure you can slip a finger between the cuff and the patient's skin. Take one of the ties and loop it around part of the bed. Now, take an end and do a lap around the other. Take a folded end and tuck it inside the wrap you just made. Cinch it tight. Now, if the patient pulls, it only gets tighter. But if you pull the quick release, voila, it's undone. Importantly, when selecting a part of the gurney to secure the tie to, make sure it's a part that moves with the patient. You don't want to raise the head of the bed only to have the patient tied down to the bottom. Restraints are best when they're not used at all, so limit their use as much as possible. Use them when you need to, but discontinue them as soon as it is safe to do so. This will minimize any risk for skin breakdown and psychological trauma for the patient. Okay, now let's see what you can do.
Yeah, the main motto of this video, they were saying that the restraint to be used when it is a need and with the least minimize appliances. Now let us come to the challenges, assumption about seclusion and restraint. Assumption one, seclusion and restraint can be used for the therapeutic benefit of people using mental health and social services. Assumption 2, seclusion and restraint keep people safe. Assumption 3, seclusion and restraint prevent violent behavior. Fourth, staff can accurately recognize potentially violent situation. Assumption 5, people with psychosocial, intellectual, or cognitive disabilities are often irrational, violent, and unpredictable. And assumption 6, there are circumstances in which the use of seclusion and restraint cannot be avoided. So, being nursing professional and we have to treat the patient, it is very important that whether how to handle the challenges while applying the patient's restraint. Now, let us discuss about what are the special points to be considered in application of patient restraint. The first important key component to be notified is restraint orders. Restraint orders will be initiated, continued by given by the order of a treating physician. An order must meet the following criteria. Number one, reason for the restraint, be time specific, include time type of restraint, reflect least reflective manner, be in accordance with safe and appropriate restraining technique, be discontinued at the earliest point in time, and never be written as standing order. Let us explain little widely about the restraint order and how it has to be taken regarding the time limitation and what are the responsibility of RN in looking after the patient with restraint. So the time limitation by the medical order is 24 hours, and when we keep the behavior health, 4 hours for 18-year or older patient, 2 hours for 9 to 17 years, and 1 hour for 8 year and under. These again, whatever the application of restraint orders are as per the WHO guidelines. Coming to the RN assessment, every 2 hours or sooner should be the medical intervention taken by the RN. And in to concern with the behavior health, continuously document every after 15 minutes. Now, emergency application restraint order by the RN, it is again, it has to be notified by the physician as soon as possible within 1 hour, and the physician must provide telephone or written order. The written order is the best, and the physician must assess as soon as possible within 24 hours when the patient is in with restraints indication. And when we need to restrain reapplication, it by the RN, it requires new order after the physician assessment. And if the original order has not exceeded the time limit, this does not include that we can have a temporary release which can occur for the patient assessment. Now, next step is like what are the observation points during restraint. The assessment include the patient physical and emotional well-being, comfort and the care need, which include hygiene, elimination, hydration and nutrition, the appropriate of the restraint application, removal and reapplication, and assessment of the need for to continue or to discontinue restraints. The second, after observation, the second points for the assessment. For assessment, the most important point is check for circulation, condition of the limbs. Attention should be given to the patient needs, including hydration, elimination, and nutrition, and check the vital signs. Restraint should be applied correctly and appropriately according to the manufacturer recommendation by the competent trained staff. And soft restraint strap can be secured to bed frame, not to side rail, in a bow or a knot that can be released quickly and easily in emergency, which you have seen in just now in a small video. Sharp objects will be kept away from the patient, and if any lock is used as a part of restraint, their key should be readily available so that restraint
इन्वेस्टिगेट करने मैं कल वो देख रही ये
immediately in emergency
व्हाट इज
situation.
आईडी संजू व्हाट इज संजू
I mean, the important point to be kept in mind while application of restraints, that is, we should have a quick release application. We should use the correct size. Next slide, ma'am, please. We should note front and back of the device. You can see some of the images are also shown. Secure to bed spring or frame, not mattress or bed rails. Do not apply one-sided restraints. Do not restrain feet when their hands are free. Place call light and necessary item within reach of the patient. Do not position pregnant patient 20 weeks or greater on their back, and it should not be on chest and waist restraint, should be used for the antenatal mothers. Let us come up to the nursing procedures. Quick review. We have to check the physician order, identify the patient, explain the procedure to the patient or his or her relatives, allow the patient to ask question or encourage him or his or him to participate in the procedure as much as possible, ensure patient privacy, wash and dry hands, arrange the article near the patient bedside, make sure the restraints are correct size for the patient build and weight, and you can take adequate assistance to manually restrain the patient. After application of restraint, the next is how to monitor the patient in restraint. So we need to monitor the patient by observation, interaction with patient, or related to direct examination of the patient by the nursing officer or a staff nurse working in the same unit. We monitor and document the medical record as following the stated interval or earlier as appropriate. Monitor the level of consciousness, orientation of the patient. We monitor the restraint site assessment for pulse, temperature, color, edema, and skin integrity. We monitor the behavior status. We check the vital sign, pulse, blood pressure, respiratory rate, hydration and nutrition status of the patient, activity and the position of the patient, and the elimination need. And the last is the range of movement of the restrained limb. This flow chart again uh, shows the key point of monitoring the patient in restraint, that is meeting the patient needs, transport protocol to be followed, assessment and the care criteria to be maintained, privacy to be given to the patient, skin integrity to be maintained, and positioning and circulation to be looked after. Some again essential point to monitor a patient in every 15 minutes are sign for any injury, circulation and range of motion, comfort of the patient, and readiness for the discontinuation of restraint. The documentation activity which has to be maintained when the patient is in with restraint as per WHO guidelines. Patient basic need must be attended, which include hygiene, nutrition, elimination, circulation, hydration, and range of motion. And in documents in the in patient record, we need physician order, initial assessment by the RN, and after 1 hour, patient actions or condition which indicate the initial and continuous use of restraint. Less restrictive alternatives can be considered. Patient monitoring and response, significant changes in the patient condition, and we need to reassess, observe, and the need of discontinuation of restraint if required. And the most important thing is education and information about restraint, which need to be provided to the patient and family. Documentation in every 2 hours for the patient with restraint is the we have to release the patient, turn and maintain the comfortable position. We should institute a trial of restrained release in between. Hydration and nutritional need to be looked after. Elimination need to be looked after. And again, give comfort to the patient and do the repositioning of the needs. Coming to the what are the potential risk and the side effects of the restraint. Coming to the physical, the main is the pressure ulcer and the skin uh, trauma, which includes many of the physiological imbalance, that there may be contracture, there may be reduced heart and lung capacity, physical discomfort may increase the pain, the patient may have constipation, increased risk of fecal impaction, increase incontinence and urinary status. There may be chances of obstructed and restricted circulation, reduced appetite, dehydration may be there, impaired circulation, and last, Yes, because of restraint, there may be chances of death because of the physiological and other complications. Coming to the potential risks and side effects of restraint, mainly psychological and emotional, patient may have increased agitation, feeling of humiliation, loss of dignity, increased confusion and fear. Now, when to discontinue the restraint? A patient will remove from restraint when on reassessment the reason for use of restraint is no longer present or when alternative strategies have become successful. But for the same, documentation is very important. If restraint are removed and alternative trials are ineffective, the restraint may be reapplied. If restraint is discontinued prior to expiration of the original order, the reinitiation of restraint is indicated. A new restraint order must be taken. As I mentioned earlier, the most important point is patient and family education, because many a times the family is in the aggressive mode, that they don't understand that for treatment purpose the restraint is used, but they have the negative attitude related to the healthcare team. So depending upon the emergent nature, the use of restraint, the reason for such use will be explained to patient or to the appropriate family members acting on the behalf of the patient. If unable to notify family prior to initiation of restraint, the family will be notified as soon as possible of the initiation of restraint as appropriate. And education need to be documented on the medical record. Another important point which is related to the patient safety is the training of staff, which is related to the healthcare team. So, training in restraint, the principles and the practice for staff nurses, including resident doctors and above, involved in the direct patient care is mandatory as the part of orientation, or at least we can have the training program on annual basis on the appropriate use of restraint. Staff is trained and demonstrate competency to the application of restraint, monitoring, assessment, and providing care of patient in restraint in the form of in-service program, induction program, or in the form of workshop is required to have a update as per the WHO guidelines. The staff need to be trained appropriate to their patient population regarding to the safe and effective use of restraint, including restraint policy of the hospital, assessment and reassessment of the patient in restraint, and ordering of the restraint. And the hospital should keep the records of training and demonstration of the competency in appropriate use of and application of restraints. This slide I was wanting to share regarding the qualitative study done by the Sandra, and it was in the Open Nursing Journal, where the study was taken from the patient and from their relatives, and they have found there were at least three themes which came out from the studies, which was so important to go to read for that first of all the relatives experience that what they perceived as restraint, even the experience of the restraint use and need to continue, and in the last theme they said that there was the lack of information about the restrictive measure. I will share the link of this study, so the so that this can be mentioned, that this point, that today again I'm thankful to Annie, that they have given this topic, where we always think that we need to teach nursing professional, but yes, there is a psychological point which we need to understand about the experience of the patient with restraints and how this point need to be considered. Coming to the some important facts related to the topic restraints. Restraints may be used to protect a patient from the greater risk of harm, although the evidence is lacking to support the effectiveness of using physical restraint or to prevent interference. The second fact, there are many studies which have demonstrated that there is no increase in serious injury when physical strains are replaced with other less restrictive safety measures based on individual specific needs. And many studies have demonstrated that there is a dramatic decrease in behavior problem when restraints are removed. There is again a video which I am sharing the link, which shows the practical approaches in minimizing the restraint, which can be shared after this session. And the next session is a participatory session where you are going to get some questions. And I request if the answer can be given in the chat box. May I read the question, ma'am?
Yeah, or I can read it for you if you want.
Anything, ma'am, in case. If you
Which
can read, ma'am,
patient
yes.
might the nurse apply a physical restraint? Out of these, which patient will you apply physical restraint? Number one, 83-year-old patient with dementia and a history of wandering, whose fall risk assessment indicates high risk of falling. A 42-year-old critical care patient with traumatic brain injury who has repeatedly tried to pull out her shunt. A 74-year-old patient confined to bed that is at risk of pressure ulcers. To which patient will you apply physical restraint? Can we see some answers in the chat box?
Yeah, ma'am, I think answers are there.
I am seeing, let me see. Number two, number two, number two, number two. Okay, madam, you need to say whether that is correct.
Yes, ma'am, that is a correct answer.
That's the correct answer, number two.
Yes,
So,
ma'am.
my question, can I ask a question? What will you do to number one?
Restraints are used to ensure patient and or
Hello, can someone answer what? How will you perform number one? May I request people to keep quiet, please? Please muted. I'll remove you from the session. I had removed somebody earlier. So please, either you are in the session or you are not there. So if you are not interested, please leave. Thank you. Yes, can someone answer? What will you do with the 83-year-old patient with dementia and a history of wandering whose fall risk assessment indicates high risk of falling? You can unmute and answer. I'm getting some answers. So let me see. They are still giving answer as two. My question is, what will you do in question number one? That nobody is answering. They answered based on
Need
what I have taught them.
Yes.
need to educate family members, ma'am.
Need to educate family members. Okay. Any other thing? Bed rail, patient safety round. Okay. Dementia patient has to allow with relative familiar environment fall preventive measures to be taken. Support or band which will signal about fall. Dementia patient with high risk of fall, side rails, relatives around. One will be with somebody will be with patient, can give sedative. 83-year-old patient, you give sedative, they will sleep for 2-3 days. Okay. So it kind of indicates it is there. It is there that you are agreeing that tying up a 83-year-old patient is probably not the right way to go about. So there is very clear-cut indications as to how do you manage in dementia. So I was trying to read something on that. So there is literature evidence where they actually made a dementia care center restraint-free policy, restraint-free.
Yes, ma'am.
They made that, they found there were less falls, less injuries. Sometimes we are deciding for them. That is not right. We just label and we tend to restrain. Okay, let's move forward. We have more questions, Dr. Geeta. Oh,
Yeah, ma'am. Yeah, ma'am. There are two more questions. No, three
okay.
more
Why does the
questions. Yes.
nurse instruct nursing assistive personnel to remove the wrist restraint of a confused patient every 2 hours? Number one, to try a less restrictive type of restraint if a more confining restraint has proved effective. To double check the size by inserting two fingers between the wrist and the restraint. To check the skin integrity and range of motion of the wrist to comply with Joint Commission standards. So what's the answer for this question? Why would you ask your colleague, assisted person to remove the wrist restraint of a confused patient every 2 hours? What's the answer? Let's see.
Yeah, they have written correctly, ma'am. Three is the correct answer.
Three is the correct answer. So
Yes.
definitely they learned. Check the skin integrity, and also there is one more thing you will do. You will tell the assistive person that please do not leave the patient's bedside. You will
Yes.
check the skin integrity, range of motion of the wrist, and inform the registered nurse so that you can decide whether you are going to continue the restraint or not. So this is actually a team effort. Now I'll come to the range of motion point in a minute. So let's finish with the third question. What would the nurse instruct the assisted person to report when caring for a patient in a wrist restraint? Tell me if the patient's pulse changes. Tell me if the skin under the restraint becomes abraded or raw. Let me know if you think she is ready for them to come off. Let me know if the patient needs anything for pain. So, what is the answer? We have great students, so all the answers are coming correct. Is it? Okay. There was a three, otherwise it is all two. So, two, tell me if the skin
Two.
under the restraint becomes abraded or raw.
Raw. That's the correct answer.
You cannot ask a assistive person to assess and tell whether the patient is ready to
Also.
come out the restraint, because that will remain with the registered nurse, right?
Correct, ma'am.
That cannot be given to them. All right, so I think we have the fourth question. The nurse is discussing the risk of falling with the wife of a patient with cognitive impairment. What is the nurse's best response when the patient's wife says, I don't like him being tied down in the bed? Number one, I'm sure you don't want him to fall again. What did you do to prevent him from falling when he was at home? We will try all other alternatives before using physical restraints. That's kind of an NCLEX-RN question. So what is the answer? Number 3333.
Correct, ma'am.
But people are very good, no? In
Or maybe my questions are very easy.
no. The problem with our nurses are not that they don't know. The challenge is what they know to action is the challenge. When a patient says that whether they will ask this or whether they will do this, because there is no multiple choice question in front of our eyes, no? When
Yes.
the patient is telling the nurse, I don't like him to be tied down. So in reality, number one is going to happen. I'm sure that you don't want him to fall again. That's the reality. But when these choices come in front, you know exactly what is right. So I really hope that all of you who are here, you are understanding what is the ethos of, communication, especially with the patient who is on restraint. Okay, number five, when a nursing Nap enters the room of a patient in a belt restraint. He finds the patient's gown bunched around the patient's chest and the patient is asking for help. What would the nap do? Check the patient's blood pressure and pulse before smoothing the gown. Untie the restraint, smooth the patient gown, put on the call light for help. Ask the patient what specific help she would like. Interesting. So let's see what's the answer. I hope you are able to picture what is the question. So we have the answers. Number two, number two, number two, number two. Are we right, Dr. Geeta?
They are, yes, ma'am. Second one is okay. Good, yes, ma'am.
Untie the restraint and smooth the patient's
Patient's gown.
hair. Okay, that's an interesting picture of restraint.
This, ma'am, the end of the slide, actually, this picture, uh, being a healthcare team, I think this picture should not be taken. But usually we always feel that when patient is aggressive, so we keep on thinking how to make them quiet. So I wanted that this picture we should not use with the theme of appropriate use of restraint.
I totally agree because I think the knowledge part of restraint is probably all there, but it is what we do when in reality, when a patient is not, able to be kept quiet, or they are, violent, or they are, irritated, or they are irritable, trying to get out of bed. So, do we actually pay a lot of attention? Is there anything else that can be done to quieten the patient? So, over to you, Dr. Geeta. Take
Yeah,
away.
ma'am. This is my last slide. The takeaway message when applying restraint. The key takeaway is safety, ethics, and necessity. Restraint, when physical, chemical, or environmental, should only be used when absolutely needed to prevent harm and must follow strict guidelines to protect dignity and well being. So, the most important essential points are that restraint should only be used when other intervention have failed. Always prioritize respect, autonomy, and informed consent. Continuous monitoring, that is, ensure frequent reassessment for comfort, circulation, and distress. Use appropriate method to prevent injury or complication. And record the reason, duration, and response to restraint use. Ultimately, restraint should be temporary, ethical, and justified, never a substitute for proper care or de escalation. These are the reference, and a big thank you to for the patients hearing. And again, I am humbled and thankful to the founder, ANEI President, Madam Tankam Gomez, for giving me the opportunity. Jai Hind, and thank you.
Thank you, Dr. Geeta. So, the floor is open for any comments or any questions because we really would like to hear from the audience here what in reality happens, because I come from an era when I used to be a critical care nurse, and I'm being very honest. When ICU patients come in, restraints are there already. The moment you intubate a patient, we used to restrain the patient. That awareness of appropriate use of restraint came much much later, and with NABH insisting policy on restraint, lot of awareness have come in. But we would still like to hear from you some of the challenges and some of the creative ways that you are trying to reduce the restraints in your setup. If you do that, then we will give you the YouTube link. And probably I will share a checklist that is created by ChatGPT. While I was listening to Dr. Geeta, I was also trying to read a little bit more, asking ChatGPT some questions, and finally I could make one, checklist and flow chart. It has come out beautifully well. Checklist of alternative to restraints. That means if you don't want to do restraint, what can be done? So I will share that image in the group if you will share your stories and ask few questions. You cannot listen to someone and just walk away, right? Yes,
Madam,
Dr.
may I?
Yes, yes.
Namaste.
Yes, Dr. Jyoti, we are able to hear you.
Yeah. This is like I feel before listening, we must know why patient is so agitated, because sometimes it may happen that because of some physiological reasons patients are agitated. So restraint may be temporary, but we have to work on the his disease condition or his changes in the biophysiological parameters. Hello.
Yes, yes, yes. So now I would like to ask questions to all of you here. I know Dr. Jyoti is still commissioning the hospital. People who are already working in hospital, can you share some alternatives to restraints that you might have tried? You know, it's very important to walk away from here, learning something practical. Where Dr. Geeta took us through how what is restraint, what needs to be taken care, responsibilities, observation, vitals, everything. So, in reality, how prevalent is the restraint, and you try something else? Hello, all the safety champions here. We had almost 150 participants here. Any CNOs or any critical care nurses, would you like to share? Okay, there are some messages coming. They don't want to talk. Chemical restraint, ma'am. Chemical restraint. Okay.
Good evening, ma'am.
Good evening.
Dr. Devinder, ma'am. So I
Fine.
can give from my like long back when I was working also in critical care unit. Mainly, it's in the head injury patient, brain trauma patients. That
Mhm.
time patients are so agitated that if you put them physical restraint, so they always fight with the bed and there are chances to increase in the ICP. So you always want physical restraining to the patient if patient has a brain injury, head injury. Otherwise, what that time we used to do, we call it as the boxer. We make every patient as the boxer gloves so that a patient can move freely and patient will not able to just take out the endotracheal tube or any lines. Mainly the initial stage. That time we used to do that. This was the only remedy as a nurses. Prevent patient harm also, and we avoid the increase in the ICP of the patient.
I totally agree with you because that takes me back to my ICU days when we had neurosurgical patients, and
Yes, ma'am.
the moment you tie any of their extremity, it is finished. You know, neither can you sedate them, neither can you restrain them. So only way was to actually do the mitten. Even the mitten is a restraint. So now I have a very interesting question to ask because nobody is raising this question. In all our hospitals, side rails are automatically put up for all patients. Do you think that is a restraint that we are doing? And are we allowed to do that legally?
Yes, it is a type of restraint.
Yes, ma'am.
Then why are we doing it? Your policy does not support to put the side rails up for all the patients. What is it, the behavior has changed? I don't know, because when I was in the hospital, all said and done, all the patients' side rails were up. Whether they have the risk of falling or not, young, old, everybody had their side rails up, except for some patients who insisted to keep the side rails down and they will say, no, I don't want to be arrested in this bed. So I would like to hear some experience from people here. Come on. We are here to learn. We are here to share our experience. Can someone share?
Ma'am, it's me Sangeeta from Guwahati. Ma'am, as this side drilling is we use as a fall prevention strategies also for the patient. Ma'am, often the patient says that at home मैं तो बिस्तर में ही रहता हूँ, मैं तो गिरता नहीं हूँ कभी. Why in hospital do you need to put the side railings on? Ma'am, in those cases, I think our communication is the key part which we have to verbalize to them that how important it is to put on the side rails, ma'am, because we also talk about those culprit drugs which can cause the fall from the bed. So I think in those cases, ma'am, communication plays an important role, ma'am.
Yes, I totally agree. Fall risk is one of the reason that we put the side rail up, and the patient needs to be educated. Fall risk assessment, if it shows, and a very good, Sangeeta, you mentioned about the culprit drug, and also the patient's unfamiliarity to the surroundings. Yes, so it can happen with us also. If when we go to a hotel, if we are not aware that we are in a hotel, I can bump against a chair on one side of the, bed, because I thought I'm at home. At home, I have nothing on the right side, but in the hotel, there is a table or a chair. I can hurt myself. So these are some of the explanations that can be given. That is still not the answer. A patient who is not at risk for fall, who is fine, who is fully oriented, who is okay. Why do we put the side rails up? Or we have stopped putting the side rails up? Can we have some candid answers?
Ma'am, actually, because of the vulnerability of the patient, it may differ, no, ma'am. Sometimes the patient had a vulnerability. There is a chance they may have a chance risk for fall. To prevent the fall, we are keeping a
No,
side
I
rails.
understand, Mala. It's a very interesting thing to go back and check. If you have 100 patients, how many of them are really at risk and how many of them have their side rails up?
Frankly speaking about according to the organizational policy, we have the vulnerability. According to the vulnerability, we have to put a side rails for safer side of the staffs also. Frankly speaking.
I understand. So I think we must admit that sometimes we are unnecessarily restraining the patient because we do not see side rail as a restraint. I hope you understand. Side
Yes,
rail
ma'am.
definitely a restraint. That is the takeaway. I'm insisting is that not just tying up or anything, just allowing their movement from the bed itself is a restraint. We must
Restraint.
understand that, that's all I was trying to drive the point. So I totally agree with those who are found at risk and vulnerability. All those patients needs to be taken care. I'm going to share an image. I don't know whether you are able to do this. I mean, it seems to be a very good document that I could get from. Let me see if I can send it across. Are you able to see this image in the chat box I have put? You can
Yes,
download
ma'am.
that.
Yes,
Ajita,
ma'am.
are you there, Ajita? Hi. Yes, Ajita.
Hi, ma'am. Good evening. You may not be able to see me because I'm outside walking.
Okay.
So I thought I'll just share. You asked for the alternative to the restraint. So if we are able to give some restraint free time where, especially in ICU or elsewhere, where a patient attendant can sit at least one side holding the hand, that the relatives touch soothes the patient, and the healing is much better. This is we are able to do it in single rooms, in some ICUs probably where there is enough privacy, or if the hospital policy permit little more time for an attendant to sit in an ICU instead of tying them up alone in a bed. That fastens the healing. Or I mean, somebody can just do this and check their they feel the patients will feel better, or the next day's response of the patient is much better. And it's a fact that we are restraining more patients because of the fact that fall is a quality indicator and you are answerable if fall happens. And the way we look at quality indicators, very restrictive manner. So these are reasons why they are forced to apply restraints, even if it is really, really not required. I know, out of fear. So the quality culture itself is a problem, I feel. Why we end up using more restraints. So because as a nursing head, if there is a fall, we first ask, what the was the patient's side rails were up, or was the patient restrained? Why didn't you take care? We the tone we talk to nurse at the receiving end definitely is one reason why there is more use of restraints.
I totally agree with you. I think we need to think of involving the family members little bit more, because I remember many a times when patients are literally violent, you cannot, and you call a family member and say, Please be with the patient," and the moment they come, they tend to calm down. Now, very important point, as Ajita mentioned, we need to do this practice and do some study in some area, and, try to bring out papers to say that something that we were able to achieve. Because I was reading about this study where a dementia center declared their policy as restraint free center, and they literally found that their falls and other complications were coming down. So yes, maybe we are very scared of the questions that may come if the patient fall, but somewhere we can start looking at, are we restraining where it is not required? Can we use the family, or we are trying to be like big authoritative, where we say no relatives allowed, you are not supposed to come here. And WHO, Saru, can you please stop sharing your screen? So where
Good
WHO talks
evening.
about engaging with the patient, engaging the patient and the relatives. I mean, there's a lot that can be done, I guess. So these such dialogues are very important, because the MCQs, whatever you give, they will get 100% marks. The question is, in real life, what are we doing? Okay. We have 2 more minutes. I think somebody wanted to talk. I don't know who was that.
Yeah. Ma'am,
Tankam, Kavaljit here.
Yeah, yeah.
I just wanted to share in one of the hospitals where I was also part of the nursing head. Spirituality, music, and palliative measures like massage with soothing oils and other things really definitely helps the patient to relax and soothe the patient and can reduce the incidences of putting restraints. That is also one of the methods which I have seen was working well.
Yes, yes. That is what this image that I shared is all kind of summing it up, looking at alternative methods. Great. Thank you, Kamaljeet. And somebody else, or are we ready to wrap up?
Can we just ask to the, so as we have got clinical practice people over there, ma'am, in labor room, I just want to ask to the participant, in labor room, do they have side rail beds, especially for the post eclampsia patient? Because I don't know what is the new guidelines where they have a labor table in MLCU, that is midwifery led care unit, so where side rails are not used. So since we have people from Guwahati and other corporate hospital, what are the guidelines for labor room for side rail beds facility? Can anybody can answer?
Those who have maternity services, can someone answer? I think Dr. Geeta is trying to ask, in labor room, do you have labor tables with side rails?
And labor table doesn't have side rail. Nowadays, the special beds are there under Lakshya guidelines. The low end beds. But I don't know whether in post eclampsia room side rail beds are there in the guidelines or not.
Geeta ma'am, it is definitely there. The eclamptic room bed should have side rails.
Sideline, yes.
Even some of the labor beds, what I see in hospitals, has side rails, and
Okay.
we may put it down when somebody is standing by the side of the lady, and because all the time, so many people are not there in labor rooms, at least in government sector. I have witnessed ladies falling from the labor bed. So we should at any cost avoid that because it can lead to catastrophe. So where manpower is less, so the bed has side rail, use it or not is our discretion.
Yeah. But usually nowadays labor tables are still there in the government hospitals labor
Without
room.
rails. Yes,
Yeah.
yes, correct. Those ones do not have rails because they are old ones. The new ones,
Yes.
okay.
Okay. Thank you. Yes.
Okay, that's kind of wraps it up. And the safe sessions always are more educative when you start asking questions and interacting. You learn more. You learn more practical tips. This is very important. So if anybody is going to do a study around reducing the use of restraints and or trying to understand what is the
Uh,
unneeded
Ma'am,
restraint,
the study topic should be prevalence of use of restraints.
that's what I'm telling.
Yeah.
Prevalence,
We don't know
especially
how
in
much.
not required,
Yeah,
that
yeah,
population. When you do a prevalence study,
yeah.
you'll come to know whether it was
How much?
really required
Yes,
or not.
yes, exactly.
If anybody is wanting to do, we can kind of, collaborate and do together, and, that'll be very, very useful.
Yeah.
Because this is one area that I don't think that we pay a lot of attention. We are only paying attention. Restraint policy should be there. There should be an order, and that's it.
Because
And
that much only is the NABH standard
yes,
say.
yes.
We are just trying
But
to.
we can go beyond NABH and see
Yes,
that beyond
that is
accreditation, what
that
is
is
really good for patients. Great. Thank you so much. And thank you for all the people who contributed. And Sangeeta, thank you. Dr. Jyoti Chaudhary, thank you. Thank you, Ajita. Thank you, Kawaljit. And thanks a ton, Dr. Geeta, for coming with
Thank
this.
you, ma'am. Thank you.
Ma'am, if may, I'm allowed to say, ma'am Geeta, it was absolutely fantastic presentation. You have touched upon all the aspects of a patient being restrained and very in-depth kind of a presentation. Really appreciate you for all the effort you have taken, and it was really fantastic presentation. Thank
Thank you. And my mentor is Madam Tankam. So under her, we are doing patient safety fellowship. So next time I'll be more technique oriented because this time some issue with my laptop happened. I'm sorry for that.
No
Apologize.
worries, no worries. We already have a backup. That is what is
That
required.
is,
Yes.
yes, ma'am. Thank you,
Okay.
ma'am. Jai Hind. Yes, ma'am. Thank
And
you.
then good night and take care.
Okay. Thank you. Thank you. Okay. Yes.
you.
Thank you.
So